Welcome to the debate. Today, we are dissecting a scenario that is the absolute stuff of nightmares for patients and a high-stakes puzzle for surgeons, the open fracture. We are talking about that moment a broken bone breaches the skin barrier, turning a closed biological system into, well, an open target for the external world.
It is a devastating injury. You have the structural failure of the skeleton combined with the biological failure of the soft tissue envelope. The stakes couldn't be higher. We aren't just talking about a wound that needs a stitch. We are looking at osteomyelitis, which is a fancy way of saying deep bone infection, sepsis, non-union, where the bone simply refuses to knit back together, and in the worst cases, amputation.
Exactly. And that is where we find our disagreement today. To set the stage, I want everyone to imagine a specific patient. Let's say a 25-year-old male, high-speed motorcycle crash. He comes into the trauma bay with a compound fracture of the tibia. You can see the bone sticking out through a tear in his leathers. There is road rash, dirt, maybe oil. In my view, this is a 5-alarm fire. My position is one of uncompromising urgency. When that seal is broken, we are in a race against bacterial colonization. I am arguing for the traditional, aggressive principles of trauma management, strict adherence to the urgency of surgical cleaning, relying on the Gastillo-Anderson classification, which has served us for decades, and damage control via external fixation to minimize catastrophic risk.
And I come at it from a different way. I believe we have been operating on dogma, specifically a 6-hour rule that has more to do with 19th century animal studies than modern physiology. I am arguing for an evidence-based evolution. We need to look at the data from major trials like FLOW and SPRINT, which challenge the need for rushed surgeries, advocate for more precise classification systems like the OTAOFC, and push for simpler irrigation and earlier internal fixation.
Let's get right into the thick of it. The fundamental premise of treating an open fracture is that from the moment of impact, it is a contaminated wound. You cannot treat it like a sterile elective case. I want to start with the mechanism itself because I think it justifies the aggression I advocate for. We aren't just talking about a cut. We're talking about the vacuum effect.
That is a vivid term, but clarify what you mean by the vacuum effect in this context.
Think about the physics of that motorcycle crash. When high-energy trauma hits a limb, the soft tissue undergoes rapid, violent deformation. It stretches out like a rubber band and then snaps back instantly. That snap creates a momentary negative pressure environment, a literal vacuum inside the limb. It pulls dirt, debris, shreds of denim, and bacteria from the road deep into the intramuscular tissue and even into the bone cortex.
I don't dispute the physics of the injury. It is in to out as the bone breaks, and then out to in as the tissue recoils.
Right. So even if you see a small puncture wound on the surface, what looks like a simple poke hole, that is often a gateway to deep osteomyelitis. The bacteria are already deep inside. That is why urgency is paramount. Time is tissue. The longer you wait to get into that operating room and debride or surgically cut away that dead tissue, the more time those bacteria have to adhere, replicate, and form biofilms. I rely on the Goliath meta-analysis here, which indicated that infection risk in severe open fractures does rise as the time to debridement increases. You simply cannot wait.
But I see why you think that, and intuitively, sooner is better feels right. It feels proactive. But let me give you a different perspective based on the actual data we have now. You mentioned Goliath, but there is nuance there. The increased risk was associated with significant delays, not the strict adherence to the 6-hour rule that has been taught as gospel for generations.
But surely you aren't suggesting that delaying surgery is beneficial. If I have a patient with a dirty bone, why would I wait?
Because rushing is dangerous. Let's talk about where that 6-hour rule actually came from. It wasn't a study on motorcycle crashes. It comes from a doctor named Friedrich in 1898. He took guinea pigs, crushed their muscles, infected them with dirt, and found that if he cut the tissue out within 6 hours, they lived. If he waited 7 hours, they died of sepsis. That is the entire foundation of our emergency mindset. Guinea pigs in the 19th century.
That may be the origin, but the principle holds. Bacteria divide exponentially.
But humans aren't guinea pigs, and 2024 isn't 1898. We have modern systemic antibiotics. Modern human data paints a very different picture. We have studies looking at, 11,000 open tibia fractures over 4 decades, showing that infection rates haven't changed much despite faster transport and surgery times. A systematic review showed no statistical association between delayed debridement up to 24 hours and infection or non-union rates.
I'm not convinced by that line of reasoning because it ignores the biological reality of bacterial growth. Biofilms, those slimy protective layers bacteria build around themselves, can begin to form within hours. Once a biofilm forms on dead bone, systemic antibiotics can't touch it. It becomes a fortress.
That is a compelling argument theoretically, but have you considered that the most important clock isn't the surgical clock, but the antibiotic clock? The data is crystal clear that the single most important modifiable factor is time to antibiotics, specifically within 60 minutes of injury. If you get that antibiotic on board, the surgical window opens up.
I agree on the antibiotics, absolutely. That is non-negotiable. But relying on antibiotics alone to hold the fort while you wait until the next morning feels like gambling with the patient's limb.
It's not gambling, it's physiological stabilization. Rushing a patient to the OR at 3 a.m. with an exhausted surgical team is often more dangerous than waiting for the light of day with a fresh team, provided that the patient has been stabilized and antibiotics were given immediately. The 24-hour window is safe. It allows for better planning and better execution. A tired surgeon making mistakes at 3 a.m. helps no one.
I think we fundamentally disagree on the panic versus urgency framing. But let's move to how we talk about these injuries. In the trauma bay, communication is life-saving. That is why I defend the Gustelow-Anderson classification. It is the global standard.
It is the standard. I'll grant you that. Everyone knows it. But is it accurate?
It is functional. If I call a colleague and say, I have a Gustelow type 3B tibia, they know exactly what that means. It means the wound is greater than 10 centimeters. There is extensive soft tissue stripping, so the muscle is pulled away from the bone. The periosteum, that crucial skin of the bone, is gone, and we are going to need a plastic surgeon to do a flap for coverage. It predicts risk. We know a type 1 has less than a 2% infection risk, while a 3B can range from 10% to 50%. It directs resources instantly.
I'm sorry, but I just don't buy that it's precise enough for modern trauma care. Let me tell you why. The inter-observer reliability of Gustelow-Anderson is only about 60%. That is, that's barely better than a coin flip. 2 expert surgeons look at the same wound and disagree almost half the time.
Because it relies on clinical judgment, which is refined by experience. You have to feel the tissue.
But clinical judgment in the emergency room is often wrong because of that in-to-out mechanism you mentioned earlier. A wound might look small on the surface, a type 1, but underneath, the muscle is shredded and the bone is stripped. Gustelow often misclassifies type 3 injuries as type 2 until the patient is actually on the table. You're undercalling the injury.
So what is the alternative? We need shorthand in a crisis. I can't fill out a 10-page questionnaire while the patient is bleeding.
The alternative is the OTA, Open Fracture Classification, or OTA-OFC. It doesn't just give you a number, it gives you a fingerprint of the injury. It assesses 5 distinct categories: skin, muscle, arterial status, contamination, and bone loss.
That sounds like a lot of paperwork when a patient is in pain.
It sounds like precision. It separates contamination from arterial status. In Gustelow, those things get muddied. With OTA-OFC, I can communicate that the skin defect is small, but the muscle damage is catastrophic, and the contamination is farm soil. That changes the surgical plan significantly. It forces the surgeon to evaluate each component of the injury rather than just guessing based on the size of the skin tear.
I appreciate the granularity, but in the heat of the moment, the simplicity of Gustelow usually dictates the immediate management. Speaking of management, let's talk about the solution to pollution: irrigation. Washing the wound out.
This is one of my favorite topics, because it is where the dogma really falls apart.
I stand by the mantra, the solution to pollution is dilution. We need high volume and active agents. My protocol is strict: 3 liters for a type 1, 6 liters for a type 2, and 9 liters for a type 3. I want that bone swimming in fluid. And I am not just using water. I want additives.
Additives like what?
Castile soap or antibiotic solutions like bacitracin or polymyxin. We are dealing with road grit, oil, maybe farm soil. You need a surfactant like soap. Think about washing greasy dishes. Water alone doesn't cut it. You need soap to break the surface tension and dislodge that bacteria, or antibiotics to kill them on contact.
That's an interesting point, and it sounds like common sense. But I would frame it differently based on the FLOW study. The FLOW trial, Fluid Lavage of Open Wounds, was a massive, game-changing study involving 2,500 patients. They put that common sense to the test. And do you know what they found regarding that Castile soap you like?
It found it was effective at cleaning, surely.
It found that Castile soap actually increased the rate of reoperations compared to plain saline. It was harmful.
Harmful? How?
Because soap doesn't distinguish between a bacteria cell and a human cell. It is cytotoxic. It irritated the tissue, interfered with the early healing response, and actually led to more complications. We were trying so hard to kill the bugs that we were killing the patient's own recovery mechanism.
That is concerning. But what about the antibiotic irrigation?
Same story. No proven benefit, and you risk toxicity and driving resistance. The FLOW study was definitive.
So you are suggesting just plain salt water?
Exactly. Saline is the gold standard. The FLOW study showed it is superior or equal to additives without the downsides. And while we are at it, let's talk about pressure. You want to blast the bacteria out with high-pressure lavage, right? Like a power washer?
You need enough pressure to mechanically debride the bone. You have to knock the dirt off.
But high pressure can push bacteria deeper into the canal and damage the osteoblasts, the very cells you need to knit that bone back together. Low to gravity pressure is preferred. It preserves the local anatomy while clearing the debris. We need to stop treating the bone like a dirty sidewalk we are power washing and treat it like living, compromised tissue.
I will concede that the FLOW data on soap is hard to ignore, but I still believe volume matters. You cannot wash a type 3 fracture with a syringe. You need copious irrigation. But let's move to the hardware. Once you have debrided and washed, you have to stabilize the bone.
And this is where the philosophy of damage control usually clashes with early total care.
For me, in a high-grade open fracture, damage control orthopedics is the safest path. You do not put a foreign body, a large metal intramedullary nail, or a plate into a dirty wound. That is asking for a chronic biofilm infection. I advocate for external fixation. You put pins outside the zone of injury, build a scaffold frame around the leg, stabilize the limb, and wait. You wait for the zone of injury to declare itself.
And while you wait, the patient is burdened with a cumbersome external frame. The pin sites are getting infected, and the muscles are atrophying because they can't move the limb effectively.
Better a pin site infection than deep osteomyelitis on an implant inside the bone. If you nail a dirty tibia and that nail gets infected, you are looking at years of misery for that patient. Multiple surgeries, removing the nail, reaming the canal, it's a disaster.
I see why you think that, but let me give you a different perspective from the SPRINT trial. This was the study to prospectively evaluate reamed intramedullary nails in tibial fractures. It showed that for most tibial shaft fractures, early internal fixation, specifically reamed nailing, is better.
Even for open fractures? Reaming sounds aggressive. You're drilling out the center of the bone?
It is aggressive, but it brings blood flow to the area. Reamed nails allow for early weight bearing. They provide superior stability compared to X-Fix. And here is the kicker regarding infection. Modern research suggests that the real threat often isn't the initial dirt in the wound, it's the nosocomial infections.
Nosocomial meaning hospital-acquired.
Exactly. The superbugs like MRSA and Pseudomonas that float around our ICUs, these bugs are far nastier than the dirt on the road.
That is a terrifying thought, but it cuts both ways.
It suggests that leaving the wound open or managing it with temporary fixation for too long actually exposes the patient to these hospital pathogens. Closing the wound early, if the debridement is adequate, and using internal fixation seals the environment, it prevents the hospital superbugs from entering, you are shutting the door on the hospital.
If the debridement is adequate, is doing a lot of heavy lifting there. That is the crux of the risk. If you close a wound that still has necrotic tissue or deep contamination over a nail, you have sealed in a disaster. That is why I prefer the staged approach. Debride, exfix, second look, then convert to a nail or plate. It allows you to be sure.
But data shows that conversion from exfix to nail has its own risks, specifically regarding infection rates if the pins have been in too long. We need to trust our debridement. If we clean it well, we should fix it definitively. It gets the patient moving and out of the hospital faster.
We cannot discuss this without touching on the pharmaceutical shield. Antibiotics. We agreed on the timing, but the selection and the edge cases are where lives are lost.
You mean the environmental exposures? The horror stories.
Yes. Let's go back to our patient, but change the scene. Instead of a highway, he's a farmer, crushed by a tractor in a muddy field. Or he's a swimmer, cut by a boat propeller in a lake. These aren't standard infections.
This is where standard guidelines fail.
Exactly. If it's a farm injury, you have fecal contamination. You have to assume Clostridium perfringens. If you miss that, you aren't just dealing with pus. You are dealing with gas gangrene. The bacteria produce gas that dissects up the muscle planes. It kills tissue instantly. You can lose the limb or the life in 24 hours. You need high-dose penicillin immediately.
And the freshwater injury?
Aeromonas hydrophila. It's a flesh-eating bacterium found in fresh water. Standard cephalosporins might miss it. You need a fluoroquinolone or specialized coverage. And if it's saltwater, Vibrio vulnificus. That one causes fulminant sepsis and blistering skin lesions. If you treat these like a standard road accident, the patient dies.
I agree entirely on the spectrum. You have to match the drug to the bug and the environment. You have to ask, where did this happen? But where I push back is the duration. How long do we keep them on these powerful drugs?
You want to stop them early?
I do. The old dogma was to run antibiotics for 3, 5, or even 7 days, sometimes until the soft tissue was closed. The modern guidelines suggest stopping antibiotics 24 hours after the wound is closed.
That feels incredibly short for a massive injury like the ones we just described.
Prolonged courses just breed resistance. They don't lower infection rates. They just ensure that if the patient does get an infection, it will be a resistant organism that is harder to treat. We treat the injury, we protect the patient during the vulnerable window, and then we stop. We don't marinate them in antibiotics.
I see the logic in stewardship, but it requires a leap of faith in your surgical debridement. It assumes you got every speck of dirt out.
It requires faith in the physiology. If the bone is stable and the tissue is clean, the body can handle the rest. We have to stop thinking we can sterilize the patient with pills.
As we wrap up, I want to summarize where I stand. While the evidence is certainly evolving, the nature of open fractures is unforgiving. These are injuries that do not tolerate error. We must treat every wound as a portal for sepsis. In my view, immediate antibiotics, aggressive volume irrigation, 9 liters for those type 3s, and a high suspicion of the zone of injury via external fixation remain the safest path. I would rather explain to a patient why we are taking a staged approach than explain why they have deep osteomyelitis.
And I maintain that safe doesn't mean rushed or aggressive in the traditional sense. The data from Flow, Sprint, and Goliath empower surgeons to be precise rather than panicked. We should use saline because soap hurts the cells we are trying to save. We should aim for a 24-hour surgical window to ensure the team is optimal. We should use the OTA-OFC to truly understand the injury. And we should close wounds earlier to shut out the hospital bacteria. We need to stop treating 21st century injuries with 19th century rules.
However, despite our differences on the how, there is one thing we undeniably agree on.
The golden hour.
Precisely. The single most critical success factor supported by every piece of literature we have discussed is the time to first antibiotic dose, strictly less than 60 minutes.
On that, there is no debate. If you get the antibiotics in, you buy the limb-fighting chance.
There is always more to explore in material. Thank you for listening to The Debate.